This presentation will investigate results and conditions regarding a 78-year-old named Patrick who was living with COPD and left-sided heart failure. Patrick's extensive history of smoking would have caused his chronic obstructive pulmonary disease. It is likely, due to his mixed symptoms, that he has a combination of both diseases that this umbrella term covers, emphysema and chronic bronchitis. The toxins in cigarettes are detrimental to all elements of the lungs and their ability to exchange gas. Particularly, frequently smoking reduces the elasticity of the alveoli and usually causes their walls to deteriorate and burst, resulting in a reduction in efficiency of gas exchange between the capillaries and alveoli. This condition is emphysema. This explains Patrick's dyspnea, as the body compensates by increasing breathing rate, creating shallow breaths in an attempt to increase oxygen supply for adequate transmission of gas. Tobacco smoke also irritates the bronchi of the lungs, resulting in inflammation and causing an autoimmune response of an influx of mucus production. Consequently, a cough is produced to try to remove the toxins. This, in prolonged smoking, is chronic bronchitis. Smoking for an estimated 40 years would have somewhat caused a continual increase in Patrick's heart rate due to the formation of atherosclerosis causing narrowing of arteries. As Patrick does not have extremely high blood pressure, this would only be one contributing factor. It is most likely that Patrick's history of his myocardial infarction is the leading cause of his tachycardia. Following his myocardial infarction, there would have been lasting damage, including weakness, infarction, and some necrosis, to the left side myocardium, due to the location of the infarction being in the left coronary artery. This obviously reduces his ability to work, so to compensate, the body would increase his heart rate to try to ensure that the living section of the myocardium, which would still have reduced blood supply, receives as much as possible to deter further necrosis to the tissue. Given the findings of Patrick's case, it is likely that the key contributor to his left-sided heart failure and his COPD is smoking. In terms of his COPD, smoking would have been detrimental to lung health due to cigarettes' highly toxic contents. These toxins impact on the ability of the lungs' alveoli to perform effective gas exchange due to destruction of alveolar walls and loss of elasticity. Smoking also causes detrimental damage to the airways of the lungs through swelling and thickening, as well as through the production of mucus obstructing the airway. Other risk factors and likely contributors to his development of COPD, in addition to smoking, include his age of more than 40, and it is likely that being overweight has exacerbated his condition. Patrick's heart failure would have also been contributed to by his smoking habits due to its involvement in the inflammation of cells lining the blood vessels, causing narrowing. Cigarette smoking also increases the formation of plaque in blood vessels. This is linked to its involvement in the reduction of HDL that allows for increased levels of LDL, a key contributor to plaque buildup. This theory is supported by Patrick's blood testing levels, which revealed low HDL and high LDL. This buildup is known as atherosclerosis. The narrowing of vessels caused by atherosclerosis causes increased pumping of the heart as a compensatory mechanism, eventually causing muscle fatigue and ineffective pumping of oxygen and nutrient-rich blood throughout the body. In this instance, myocardial infarction to the left coronary artery occurred, causing necrosis of tissue and further impairment of cardiac function. Consequently, Patrick is now living with left-sided heart failure. Although Patrick's COPD and left-sided heart failure are primarily due to his smoking habits, it is unlikely that one led to the development of the other. COPD is a result of lung damage, as mentioned previously, due to contributing conditions including emphysema and chronic bronchitis. Left-sided heart failure occurs due to failure of effective pumping, causing impaired ejection of blood from the heart and congestion into the pulmonary circulation. Due to this variation in their development, it is justifiable that the conditions developed independently of the other. However, it is possible that these conditions exacerbate the other. In left-sided heart failure, congestion in the pulmonary circulation leads to increased pressure in pulmonary capillaries. This forces fluid into interstitial spaces and alveoli, a condition known as pulmonary edema. As a consequence, increased respiratory function is needed for adequate ventilation and decreased gas exchange occurs. At this point, it is justifiable that Patrick's left-sided heart failure would exacerbate COPD. Likewise, COPD involves impaired gas exchange, which has an effect on the cardiovascular system by reducing oxygen supply to the myocardium muscle as well as other body systems. Reduced oxygen supply to the heart muscle leads to myocardial ischemia. Compensation for myocardial ischemia involves increasing pumping action as an effort to get blood to the deprived cells. Consequently, workload is increased, muscle fatigue becomes apparent, and heart failure is exacerbated. Patrick is at risk of developing right-sided heart failure for several reasons. His history of infarction in his left coronary artery puts him at risk of left-sided heart failure, as that artery is the primary blood supply to the myocardium. The left coronary artery also supplies blood to the pulmonary artery. Currently, in his condition, this blood supply would be impaired, limiting the blood and therefore the function and strength of the pulmonary artery, resulting in slower flow of blood to the lungs. But as his body is currently compensating by increasing heart rate, Patrick's right-sided myocardium would be working at an unsustainable rhythm, and if left untreated, it will cause right-sided heart failure as his heart will not be able to maintain adequate amounts of blood to the overworked heart. Another aspect of Patrick's condition that puts him at risk of right-sided heart failure is his declining respiratory function and worsening COPD. This puts him at risk of developing cor pulmonale, a specific type of right-sided heart failure primarily caused by pulmonary hypertension. Patrick's impaired gas exchange will cause a slowing of blood flow through the alveoli as an inadequate amount of oxygen is being transferred. This in whole will demand an automatic compensation by the body, increasing the pressure in the pulmonary artery in an attempt to restore normal speed. This increased pressure, if prolonged, will eventually cause a change in the structure of the right ventricle by building more muscle to maintain the heart's ability to push the blood at the required pressure. If this becomes chronic, it causes right ventricular hypertrophy. This cemented structure is not maintainable, efficient, nor safe to live with. Worsening of left-sided heart failure may increase the chance of having chronic kidney disease, leading to low GFR, which could be the reason of high potassium level in Patrick. Patrick could be potentially using ACE inhibitors for his heart failure, which block the stimulatory effect of angiotensin II on aldosterone secretion, resulting in increased risk of hyperkalemia due to consequent reduced potassium excretion. Hyperkalemia can lead to muscle weakness, cardiac dysrhythmias, nerve and muscle problem weakness, tingling, numbness, and paralysis. Patrick's history of myocardial infarction might have impacted on kidney perfusion and activation of renin-angiotensin-aldosterone system, which results in retaining of sodium and water. Hyponatremia causes cellular dehydration, leading to headaches, intracranial hemorrhage, lethargy, and possible coma and death. Left-sided heart failure decreases the adequate perfusion of systemic circulation as well as lowers oxygen content in the blood, leading to low hemoglobin level. COPD and chronic inflammation make the red blood cells die faster than in healthy individuals. Smoking is also a contributing factor for low hemoglobin. Low hemoglobin increases risk of dementia in individuals with chronic hypoxia, which accelerates cognitive decline and increases the risk of brain disease. Patrick is at increased risk for vitamin D deficiency because of his age, history of smoking, COPD, and high BMI. He may also be less likely to have outdoor physical activities because of his COPD, swollen leg, and tachycardia, which deprives him from getting vitamin D and low calcium occurs. Hypocalcemia may bring numbness, hallucinations, tingling, memory loss, anxiety, irritability, and depression. Patrick's reduction of HDL allows for increased levels of LDL. History of smoking and his age are the contributing factors for high LDL, low HDL, and high triglycerides. His BMI of 29.3 also indicates Patrick is overweight. If left unmanaged, this could lead to obesity, which is fundamental in the manifestation of metabolic syndrome, which includes hypertriglyceridemia. Hypertriglyceridemia results from overproduction of triglyceride-rich lipoproteins. High LDL and low HDL may contribute to cognitive disorder and risk of Alzheimer's and Parkinson's disease. Memory loss, dementia, and depression are neurological symptoms of hypertriglyceridemia. Chronic obstructive pulmonary disease may be considered as a risk factor for new-onset type 2 diabetes mellitus via multiple pathophysiological alterations, including inflammation and oxidative stress, insulin resistance, disturbance in glucose metabolism, weight gain, and alterations in metabolism of adipokines. History of smoking has contributed to Patrick's increased resistance to insulin, which has elevated his glucose level. Hyperglycemia can increase the risk of damage to the small blood vessels in the brain. This damage affects the brain's white matter, where thought patterns are changed and vascular cognitive impairment or vascular dementia occur. A brain natriuretic peptide blood test can be done on Patrick to evaluate his cardiac condition. BNP is the hormone secreted by membrane granules in the cardiac ventricles, especially in the left ventricle, due to stress or changes in pressure inside the heart. The BNP test helps to identify the presence of cardiac failure, determine severity of left ventricular dysfunction, and estimate prognosis. In the normal adult, the level of BNP is less than 100 picograms per ml. In the case of Patrick, left-sided heart failure is worsening, so the level of BNP is expected to be high. The level of BNP rises when heart failure is developed or when it is worsened. Similarly, the level of BNP is increased in the case of cardiac ischemia, arrhythmias, pulmonary disorder, and kidney disorder.